So topic for today is what goes into a dementia diagnosis. And I think kind of the first thing to start with as it relates to that, let's see, that's how I do that. So first thing is kind of defining terms and what we mean by a dementia diagnosis, because as it turns out, dementia is a word that is not a diagnosis in itself. It isn't a specific disease process. To say that somebody has dementia is not, making any judgment about what is causing that patient's symptoms or what might be going on, what we need to do to treat it. All it is an observation of how, a patient's life is affected. So I sometimes like to say that you don't come to me and have me tell you that you have dementia. You come to me saying that you have dementia, and I try to help you figure out why and what we need to do about it. So this is not a specific disease process. The definition of dementia is cognitive decline. And when we talk about cognition and cognitive things, we're talking about thinking, memory, personality, things in that realm. So this is a decline in cognition that impairs your ability to function independently. So if you are noticing cognitive changes, memory changes, thinking and reasoning changes that are impacting your quality of life such that you are needing assistance with some of your activities of daily living, which we're going to talk a little bit more about. By definition, that is dementia. Not any particular diagnosis, not any particular disease process, just that is the word that we use to express that you're having that experience. And so, sometimes the question is phrased in a way as, what's the difference between dementia and Alzheimer's disease? They're kind of two different categories. Alzheimer's disease is a disease process. It's telling you what kind of pathology is happening in the brain. Dementia is basically the symptoms that you have because of that. So it's an umbrella term including a number of different things that we're going to talk about, because once we decide somebody has dementia or the precursors of dementia, the next question is, well, what's causing that and what do we need to do about it? So we have to kind of distinguish certain things from one another. So I mentioned a big part of the definition of dementia is the help that you need on a daily basis to do your activities of daily living. And so to define those further, there's two types of activities of daily living. The basic ones are dressing, bathing, grooming, feeding yourself and using the toilet without assistance. And then there are more complex things that, that are a little harder to do, require more complex behavior, and that are usually the first things that are affected, the first things that you kind of start to need assistance for. So that's things like driving, or otherwise managing or arranging for your transportation. If you're starting to need somebody else to help you arrange for how you're going to get places, that's kind of one instrumental ADL. Other things are managing your own medications, managing your personal or household finances, keeping track of appointments and events, keeping a calendar, managing your schedule without somebody else needing to kind of give you reminders or kind of keep that organized, making a shopping list and shopping, and also just kind of the basic activities of kind of maintaining your household. So keeping your living space clean are all kind of instrumental activities of daily living. So the way that those fit into a diagnosis, kind of getting to the specific diagnosis of where somebody is at, another very, very common question, that I get from patients and their caregivers is, what is the stage here? And there are a number of different kind of very complicated and numerical scales out there that different people publish and give them fancy acronyms and things like that. The common element there is that they're all based on functional independence and level of functional independence. And so what we prefer to do in kind of science-based and academic medicine is really focus on how a patient's life is impacted and stick with kind of these more descriptive terms. So you can see kind of in the chain of events here, you go from normal functioning to mild cognitive impairment, followed by mild, moderate, and severe dementia. So kind of the sharp line here that we already talked about happens between mild cognitive impairment and mild dementia. And that's the line that you cross where you start to need help with those activities of daily living. So from normal functioning, where you don't even notice any changes in your thinking and you're obviously completely independent with all those basic and instrumental ADLs, which I'm going to simplify just by kind of using column A and column B here, that are kind of listed for you again. What we define mild cognitive impairment as is something where you do notice that something is different. There is a cognitive decline, but it is not yet affecting your functional independence with kind of any of those activities in column A or column B. When that crosses over to mild dementia, you know, that is a person who is still completely independent with all the activities in column A, but is starting to need some assistance with some of the things in column B. And then when that progresses to moderate dementia, that's the point at which somebody is needing assistance with all of the things in column B. And then as far as the things in column A, maybe not needing assistance with those, but starting to need some prompting, you know, not really doing their you know, daily hygiene or bathing, changing their clothes without somebody helping to remind them that it's time to do that. Severe dementia is reserved for when somebody is fully dependent for all their activities of daily living, including needing full assistance to feed themselves, use the toilet, things like that. And oftentimes, you know, there's also a lot of difficulty with expressing oneself verbally and with getting around without assistance as well. And that's the stage that we call severe dementia. I'll notice I don't have it on this slide, but one thing that we notice is that this is rarely, and again, kind of like Loretta pointed out, everybody's experience of the disease is a little bit different, but it is pretty rare to see a very, very consistently steady decline going through all of these, kind of taking the same amount of time in them. What we typically see is that patients won't notice anything is wrong at all, even though we know, you know, kind of from studying all these conditions that, you know, the changes happen very slowly and gradually in the background, and, you know, for a very long time people are able to compensate, and then there's usually some, you know, some point in time, usually some change, either a change in living situation, moving house, loss of a close family member or other loved one, an illness, a hospitalization, surgery, or something like that that causes it to be harder to compensate. And at that point, for the next few months, there will seem to be a pretty sharp and quick decline in activities of daily living. Then in that mild cognitive impairment or mild dementia stage is usually where people will reach a nice long plateau, such that they don't notice, you know, real significant changes, certainly not on a month-to-month basis, but even year to year, it can seem very minimal as far as changes in the type of help that they're needing. And then later on, you know, that does tend to progress, and at that point, it'll seem to be progressing a little more quickly. But our goal in managing these things is to kind of really, you know, really draw out that plateau range where people are still able to do the things that they enjoy doing for a good long time with minimal assistance. And so that's kind of where we focus our attention. So The medical evaluation that we do as part of the diagnostic process is based on the questions that we need to answer. One big one is, before saying this is something that is irreversible and relentlessly progressive, like most of the common causes of age-related cognitive decline, let's make sure that we're not missing something that is completely reversible or completely treatable. So the really common ones there are sleep disorder, a mood disorder, and an anxiety disorder that can often get quite a bit better with proper treatment of those conditions. And then kind of some of the more conventional things that we call a reversible cause of dementia are things like vitamin deficiencies, like vitamin B12 deficiency, and certain types of infection. Traditionally, syphilis has been the big one there that can cause something that looks very much like a neurodegenerative dementia, becoming less common now because we have such good antibiotics for it. In the absence of one of those conditions, when it's looking very much like a neurodegenerative cause, we try to answer which one of the neurodegenerative conditions we think it is. And even though we don't yet have disease-specific, disease-modifying therapies that treat that underlying cause of the disease, we think it's still important to get the answer right, not just because eventually we will need to be making that determination to kind of pick the right treatments, but also it helps us give the patients and their loved ones the best information they can as far as what to expect, what the prognosis is, what kind, how the, process might unfold, symptoms that they might not have now, but they, may want to watch for because they would need to be, they'd need to be managed. And also depending on the condition, certain things respond to different treatments a little differently, symptomatic treatments. So kind of regardless of the underlying cause, certain conditions do respond to various treatments. Like some will do better with medication, some will do better with speech therapy, and so we think it's important to kind of get that diagnosis right. And then as far as guiding our management of symptoms, we really focus on what's impacting quality of life. So, even if somebody is experiencing, really bad memory decline and, repeating themselves a lot, if that's not bothering them, but they are having visual hallucinations of really frightening people and animals in their house that are making them scared, that's what we're going to try to treat. We're going to try to make that go away more than anything. And sometimes we can do that by simplifying the medication list, stopping a medication. We try not to do is just add medications on top of medications. So kind of take a look at what's impacting quality of life and take a careful approach to managing those symptoms. So, so that's what the evaluation looks like. So how does it get started? Who comes to us? How do they end up, either knowing that they need to seek out a referral or, that their primary care physician, what does their primary care physician identify that, leads them to send them to somebody like myself? So, the key things are having new difficulties with those cognitive functions, memory, attention, language, decision-making, that are definitely a change from before. So not a long-standing lifetime difficulty. These are things that have a slow and gradual onset. So not something that we think happened because of a stroke or a traumatic brain injury or something like that, and that are significantly impacting somebody's quality of life. If they're noticing changes, but it's not a problem at all, it may just be kind of normal cognitive, normal cognitive changes that happen over time. We'll talk a little bit about that in a couple slides. Importantly, these kind of things that are considered dementia, all of those types of symptoms can be noticed in the context of an acute illness, like a hospitalization or an infection. Urinary tract infections are notorious for making people very, very confused and producing symptoms that look a whole lot like dementia in people who don't have a dementia-causing brain process going on. Same goes for urinary retention, especially as men get older and the prostate enlarges. That can become a bigger problem. Or, just kind of swings backwards and forwards in blood pressure, blood sugar can produce those episodes of confusion as well. So, if you think you're noticing that, some questions to ask about yourself or a loved one. Problems forgetting appointments or details from recent conversations. Are you relying more heavily on written reminders, schedules, calendars, and is that a change? Having word finding difficulties, difficulty recalling names of familiar people, or not recognizing places that should be familiar to you, things like that. So these are all things that, we often hear as part of the history and that would prompt you to seek out an evaluation. So, they mentioned that dementia itself does not tell you what the disease process is. So what are the common things that we want to differentiate from each other? Obviously, far and away, the most common cause of age-related cognitive decline is Alzheimer's disease. And that's the majority of what I see, my colleagues as well. But, it's important to differentiate that from other causes that can often look similar, such as vascular cognitive impairment due to either multiple strokes or just the slow and gradual changes that happen to the very small blood vessels in the brain as we get older, or other neurodegenerative conditions like dementia with Lewy bodies and the frontotemporal dementias, which is actually kind of an umbrella term for a group of dementias. Other than the vascular cognitive impairment, all the ones on this slide, the Alzheimer's disease, dementia with Lewy bodies, and frontotemporal dementias, have in common that they are caused by proteins in the brain that stick together, get stuck in the tissue, and cause damage in doing so. In all cases, it's different proteins that build up in different parts of the brain, but that is kind of the slow and gradual disease process in each of these neurodegenerative conditions. So in distinguishing those from one another, there are certain things that kind of, that kind of point to one or another. So dementia with Lewy bodies is usually more than just memory problems and cognitive problems that are apparent even at the outset. So Parkinsonian movement symptoms like the classic tremor that most people are familiar with, walking with a more hunched over posture and shuffling your feet, being slower with your movements in general, and having real stiff and rigid arms and legs is something that points in that direction. But also visual hallucinations are very common even early on in dementia with Lewy bodies, as are behavioral disturbances. Typically, and one of the diagnostic criteria for this, or the cognitive symptoms tend to fluctuate quite a bit. So that means really good days and really bad days, and periods lasting hours at a time where someone can be really, really confused, even if just a few hours before they were having a completely normal conversation. Mentioned vascular cognitive impairment. So this is different from Alzheimer's disease in that it's more kind of thinking, planning, problem solving, reasoning that are affected more than memory. Processing speed as well. And not as much kind of that short-term memory formation and retrieval, although that is often affected as well. And like I said, it can be from a collection of strokes or from slow and gradual change to the blood vessels. The frontotemporal dementias, as I mentioned, are kind of a group of diseases, not nearly as common as dementia with Lewy bodies or Alzheimer's disease. These are young onset dementias. So whereas both AD and dementia with Lewy bodies tend to affect people in their 70s, 80s, even 90s, average age of onset of the frontotemporal dementias is about 55. There are kind of three distinct clinical syndromes that are associated with the frontotemporal dementias. One of them mainly impacting behavior and having kind of psychiatric symptoms more than cognitive symptoms. People doing and saying things that are out of character for them. And the other two are types of aphasias, where the main problem is in using language, either expressive language or just kind of knowing what words mean, knowing kind of the meanings of words and objects and things like that kind of degrades over time. So, that's kind of what our task is differentiating these from one another. And, whereas these are often the case, not everybody looks, not everybody is going to kind of present with a textbook type set of symptoms. And so oftentimes we have to, approach this very carefully. So as far as truly diagnosing these neurodegenerative conditions, to make a definitive diagnosis for any of these, the one and only way to do that is with a slice of brain tissue on a slide stained with certain types of stains and under a microscope. Now, obviously, that is not something that we can do to diagnose these while you're still using your brain. And it's something that we have to wait, until autopsy and those that choose to go that way. So just to include in this discussion of how to diagnose these conditions, this is what, kind of the diagnostic tests actually look like, is seeing these characteristic lesions on neuropathology. So we're going to limit our discussion to making that clinical diagnosis of what we think the most likely of these processes is going on in the brain. So these are the main components of the diagnostic evaluation. And I really want to emphasize the importance of that top line there, the history. This is the discussion that you have with a neurologist or another physician. It's often said about many things and kind of in an exaggerating way that history is 90% of the diagnosis. And I have to say that in this case, that's not at all an exaggeration. So whereas it often seems like there's so much happening with kind of these high-tech scans and lab tests and things like that, those are just helping us answer little pieces of little questions here and there. For the most part, the main decision making that happens diagnostically happens because of the discussion, because of elements of the discussion, elements of the story, the things that have happened to you, what you tell the doctor. And a lot of the other things on this list are prompted, certain tests are needed or prompted because of things that you mention in the history. So this is really, really important. We definitely put a lot of emphasis on trying to get this right, ask the right questions, and really get a good sense of what the pattern has been, what the time course has been like of the symptoms that you've been noticing, because that'll often point us in the right direction. Along with that history taking, there will always be a neurological exam, a physical exam, but also some exam of kind of a screening exam of cognition. I'll talk about a couple those that you may have seen. We usually get labs as part of ruling out some of those reversible causes. And then oftentimes we will include imaging. I think in a discussion about comprehensive diagnosis and things, oftentimes your mind might go immediately to the cutting edge, real high tech, new PET scans and things like that. But really, those are only indicated in a small minority of cases. The type of imaging that is most helpful in kind of making these diagnoses is regular structural imaging with an MRI. And oftentimes, that can help us in making the decision. Not necessary to make these diagnoses, but often helpful in kind of confirming or pointing us in a different direction. Similarly, in some cases, formal neuropsychological testing with a neuropsychologist, a PhD neuropsychologist, can be helpful. Now, if the history is very, very clear and definitely fitting a pattern, and on our neurological exam, we see exactly the pattern that you describe, and it is classic for one of the neurodegenerative conditions we see frequently, then this is not always necessary, and it is it's not super easy to to go through these. Many of you have probably kind of seen how this is done. Usually takes 3 or 4 hours. The tests are not easy. They challenge you. They make it harder until until you can't do the cognitive tasks. And so, it does give us good information, though, as far as aiding our diagnosis. Then the other ones that I mentioned on here are really just if the history, the exam, and all the other data is just looking a little weird, does not look classically like any of our conditions, or it looks like it could be one of two different conditions, or maybe a combination of them, is when we will sometimes get these higher order tests. And so that's things like a spinal tap for biomarkers in your spinal fluid. And then some of those advanced imaging PET scans, and I'll go over a few different versions of that. In certain circumstances, an EEG can be helpful. So if you're describing really discrete episodes of kind of not paying attention or not responding, and then it's followed by a period of confusion, sometimes we'll wonder, are there seizures happening? Is somebody starting to have seizures? And then very classically, after a seizure, someone for a period of 20 minutes to several hours can be very confused and can seem like they have cognitive impairment. So sometimes that's something we need to rule out with an EEG. Sometimes other kind of more specific lab tests, like looking for autoimmune antibodies, if there's kind of something that jumps out to us about the story, usually in somebody with cognitive symptoms and behavioral symptoms, seizure-like episodes that come on a lot faster, progress a lot faster, and in somebody who's a lot sicker has kind of other general body symptoms as well. We think about these kinds of things. Sleep study, very important in certain circumstances, particularly if there's something in the history like loud snoring, gasping for breath at night, trouble waking up and not being able to go back to sleep, things like that. So these are all things that are often prompted by either something about the case that doesn't make sense or something that comes up in the history. So when we're taking the history, a very, very important first step is deciding, is this just normal cognitive aging, which is a thing, or is there something more than that? Is there something like an age-related cognitive decline like Alzheimer's disease, so due to a dementing process like that? So what normal cognitive aging looks like is very gradual, very subtle, usually doesn't, impact quality of life in a significant way, and it actually begins in your 30s. So everybody, kind of has some slow decline, especially in processing speed over the course of their adult lives. And, so this means it just takes a little bit more time and a little bit more effort to do cognitively demanding tasks over time. So you show slow decline in the processing speed, as well as in certain kind of reasoning activities of your frontal lobe, problem solving, things like that. Takes more effort, takes more time. One thing that is not affected by normal cognitive aging is vocabulary. And so if you're starting to use simpler words than you did before, or fewer words, simpler sentences, that's not typical. What we'll usually say is that if you live to 105, your vocabulary is better at 105 than at 104. You keep learning words, you don't lose those. It's a type of learning and a type of memory that doesn't depend on those brain structures that are most affected by age-related cognitive decline. Similarly, your general knowledge, things that you learn in school, what things are, what things mean, when things happen, doesn't tend to be affected. So as part of the history taking, we'll want to hear what kinds of things, what kinds of difficulties have you noticed, or have the people around you noticed with your memory? Are you repeating yourself, asking questions that you've already asked before? Do you have details missing from conversations that you had just recently, a couple hours ago? And then very, very important, can you be reminded of those things? Is the memory there and is just harder to retrieve, or is the memory just not even there in the first place? So, to get to that, we try to figure out, do cues or reminders help you recall those things? There are certain things that people will say in telling the history that kind of give us a sense of whether the memory just wasn't formed or that it's just a little harder to bring it up. Are people getting disoriented in places that should be familiar to them? Or, is it taking them longer to recall things that used to be easier for them to recall? And then there are other things, and this is mainly an exercise in trying to tease out, are there signs of those non-Alzheimer's disease causes of cognitive decline and dementia in what people are experiencing? So non-memory symptoms like psychiatric symptoms, particularly personality changes, social withdrawal, loss of a filter, so saying things that you would otherwise kind of hold back from saying because you think they might be inappropriate. Words coming out wrong, so mispronounced words or using the wrong word in place of the right word and not really noticing that you're doing it. Having difficulty putting sentences together, having difficulty knowing what words mean, are all language symptoms that we try to get as part of the history. These are all things that point to, as I had mentioned before, oftentimes the frontotemporal dementias. And so we'll really, in younger patients that are presenting, we'll really try to assess for whether they've noticed anything like that. Visual hallucinations as well, usually of people or animals, are things that we want to, we want to hear about. And likewise, acting out dreams. So both of those things, the acting out your dreams and visual hallucinations, are kind of diagnostic criteria for dementia with Lewy bodies. So, if we're hearing that as part of the history, we're going to focus a lot on the neurological exam, on the movement exam, and trying to see if there's any signs of those Parkinsonian movement changes. And then, are there changes in mood? Is there worsening depression? Have there been changes that have caused you to lose interest in the things you used to really enjoy doing? It's important for a couple of reasons. As I mentioned, that's kind of one of those reversible or treatable causes of cognitive impairment, is mood disorders or anxiety disorders, but also that impacts quality of life a lot. And we can, we're trained to help manage those types of conditions as well. And so we want to help out where we can. It's really important to manage the mood and anxiety symptoms wherever they're present, with both medication and non-medication approaches. So in addition to the history, we want to get some sort of, sense of what types of things are harder for you to do objectively. So there's the things that you've noticed, but we want to see in an objective test, and this is nothing like what they do at neuropsychology, but different providers will kind of utilize different tests to try to see what the pattern is. And my preference is the one on the left here, the Montreal Cognitive Assessment, the MoCA. There's one that was developed at Ohio State that I put on the right here. I think this is a really cool one because this doesn't need a provider at all this is one you could print off the internet basically and do it, can completely administer it yourself, and it's validated and accurate. What I use this for in the context of my office visits is not necessarily to get to a numerical score. I don't really place a lot of importance on what that numerical score out of 30 is on the MOCA. I want to see how a patient is approaching these tasks, and what types of things are taking them longer, what types of things are more difficult for them to do. And in particular, this one includes a pretty difficult delayed recall task that you can make easier with different types of cues. And like I said, one of the big questions is whether the memory was formed in the first place, that short-term memory, or whether it's just, a difficulty in efficiently pulling that up. Cues can help with it. And so this is one where it kind of presents you with 5 words that have nothing to do with each other. You have no reason to associate them with each other, ask you to remember them, and then kind of cruelly distract you with 12 other things to do before I ask you again in 5 minutes what those words were. And so it's not an easy task, and kind of seeing where people struggle with that can kind of point to what is affecting their memory in their daily lives. So structural imaging is also very important. So this is kind of pointing out the changes that we look for in Alzheimer's disease. So they're mainly changes of volume loss. And these are 3 different brains taken at the same level. This is kind of as if we're looking at you face to face and kind of taking a slice right through the middle. And that kind of black butterfly in the middle in each case is the fluid-filled spaces in the middle of the brain called the lateral ventricles. And you can see that kind of as the middle part of the brain, the middle structures of the brain lose volume, that can expand. And so kind of on the farthest right scan, you can see kind of significant enlargement of those ventricles, but also these spaces. I don't know if you're able to see my cursor, but the spaces between the frontal lobe and the temporal lobes, called the Sylvian fissures, they open up as well, and kind of some of these spaces between the finger-like projections on the outside of the brain that we call the cortex open up. You can see a lot of that opening up, the space between the brain and the skull, and space on the outside of the brain in this middle image as well. The thing that I really want to emphasize here is the size and shape of the hippocampus, which is right here in the middle part of the temporal lobes. That's our main memory formation and retrieval structure. It's the first structure affected in Alzheimer's disease. And so we want to pay careful attention to that and see if there's any signs of volume loss. The signs of volume loss that we look for are kind of an expansion of that fluid-filled pocket around it. So as it kind of thins out, you can see it kind of taking this more S-like shape rather than this full and round structure, and pockets of fluid, these black areas around it opening up a little more. And then you can see by the one on the right here where there's severe flattening of the hippocampi on both sides, kind of severe volume loss, very thin, very small, that there's a big open pocket right next to the hippocampus, and that indicates volume loss. A couple other things that we're looking for on our structural MRI is other things that, kind of other areas that could indicate damaged tissue. So on the left here, we have kind of the telltale signs of chronic ischemic disease. So this is slow and gradual damage that happens to the brain due to the changes that happen to the smallest blood vessels as we get older. So, basically we've got a few large blood vessels that feed the brain. They branch into smaller blood vessels and smaller blood vessels. And where the blood supply from one large vessel meets the blood supply from another large vessel is what we call a watershed region. And if those little blood vessels that you're relying on in those regions get more brittle, are not letting as much blood flow through, there can be ischemic changes that happen. And those are the same types of changes that happen in strokes, but in these cases, it happens very slowly and gradually. And if there's enough of it, everybody has a little bit of that with just normal getting older. But if there's enough of it, it can cause symptoms, and often symptoms of cognitive impairment. So we look for that as well. On the right here, we see severely enlarged ventricles. And so this is more than just there being a volume loss of the structures around it. This is the ventricles blowing up like a balloon. And this is an MRI from one of my patients who has normal pressure hydrocephalus. So this is another potentially treatable form of cognitive impairment and dementia. Usually affects not only your thinking and memory, but also affects your ability to walk, difficulty picking your feet up from the floor, and urinary incontinence as well. So when we see that in the history and we see enlarged ventricles on the exam or on the MRI exam, it may be a case that needs to be seen by neurosurgery to talk about a surgical way to decompress those ventricles. And that can often lead to a really dramatic improvement in symptoms. And so that's not something we want to miss. Another reason that structural brain imaging is very important. So we oftentimes over the course of kind of seeing lots and lots of MRIs, we get a really good qualitative sense of, whether there's volume loss that that is more than we expect to see just with normal aging. But we oftentimes have get a little help from technology, and in some places, not the MRIs that we get through UCI, but there are places where NeuroQuant is available, and this helps people like primary care physicians who aren't as used to looking at looking at the structural brain MRI as frequently, to know what is normal for a given patient's age, and kind of plots what the expected size of the hippocampus is given a patient's age, and also the size of those fluid-filled structures, the fluid-filled spaces in the brain called the ventricles, to tell if there's been some expansion of that or some hippocampal volume loss. And so that's another tool that's available with structural brain imaging. As I mentioned, the neuropsych testing is kind of 3 to 4 hours with a neuropsychologist, where they'll give you tasks that involve kind of visual-spatial reasoning, language abilities, testing your memory in a number of different ways, and then just general problem-solving things. And these can involve kind of paper and pencil tasks that you do just by answering things out loud, and also construction tasks where you're using blocks or pegs to kind of solve puzzles of increasing complexity. So when we get the report written up by the neuropsychologist, they give us a very, very detailed multi-page report about the pattern of difficulties that a person had, not just what was difficult for them, but what their strengths were. So, what things did they perform in the expected range for? What types of things did they struggle a little bit with? And what types of things did they, find to be not a problem at all and do even better than expected? And so this kind of gives us a picture of, what cognitive domains are affected and to what degree. And that pattern is very, very different in different causes of dementia, different neurodegenerative conditions. So that often is a big help in the diagnostic process. So when we talk about cognitive domains, I listed a bunch of them that we'll often talk about here. So memory, language, executive function. And again, as far as the memory, that is, there's a number of different ways to evaluate that. Some of them being, are you forming the memory? Some is it just difficult for you to recall the memory? Does it help if the information is structured like a story? Or, do you only have problems if it's unstructured, like a word list of completely unrelated things, or an abstract set of shapes that, don't look like anything you'd see in your daily life? And then executive function is those kind of reasoning and problem solving skills, attention, visuospatial skills, expressive language, and comprehension side of language. And then again, kind of overarching all of that, what is your processing speed? Does it take more time and effort to do these tasks? the blood tests that we do are looking for kind of treatable causes of memory impairment. So low thyroid hormone level is one of those things that is very easy to fix and can kind of improve your thinking. Vitamin D, vitamin B12, and then signs of infections that can cause dementia like syphilis and HIV. And so that's kind of the basic screening that we do in somebody who's presenting with memory disorders. Now, like I mentioned before, there's sometimes a need to get kind of higher level labs, and this often involves looking at certain markers in the spinal fluid with a lumbar puncture, a spinal tap. So this is in a case where, we think it might be Alzheimer's disease, but the story and the exam just don't quite fit a classic picture of it. And we need more information before we say, yes, let's stop looking for other causes. This is probably Alzheimer's disease. And so, the best validated confirmatory test for Alzheimer's disease is something that looks at two different proteins in the spinal fluid. One of them is a version of the amyloid beta protein that often makes up those amyloid plaques in the brains in Alzheimer's disease. When those plaques start to form, the amyloid beta, the one that we're looking for, is called A beta 42. The A beta 42 gets stuck in those plaques and doesn't make it into the spinal fluid. So we see a decrease in that. And then as the other protein that is affected in Alzheimer's disease, the tau protein, as that goes bad, more of it is in a form that we call the phosphorylated form. And that does get into the spinal fluid. And so we look for an increase in the phosphorylated form. And so a decrease in A beta, so that's along this straight up and down dimension, and an increase in the phosphorylated tau puts you in this lower right-hand box on this graph. And that is the box that is most consistent with Alzheimer's disease. So if we have somebody who has an equivocal story and exam for Alzheimer's disease, but they have CSF biomarkers that are in this box here, we can pretty safely say that, we are dealing with a diagnosis of Alzheimer's disease. These are, a very similar kind of approach is when we need additional, evidence that, it is one type of dementia versus another. We can often use these PET scans. What you may have heard most about, because it gets covered most in the press these days, is the special tracer PET PET scans. So that would be like the amyloid PET scan. And there's a newer one that is the tau PET scan. So these are using kind of IV injections of tracers called Amyvid or florbetapir or flortaucipir. And this is kind of what the results look like on the bottom here. And sometimes I find the popular press treatment of these type of scans to be kind of annoyingly misleading. They'll often talk about how it's showing you where the plaques and tangles are. It's showing you how many plaques and tangles there are in the brain. As I showed you before, plaques and tangles are things that you can only see through a microscope on a stained piece of brain tissue. This comes nowhere near showing you plaques and tangles and is several orders of magnitude cruder than that. So what it can tell you is, in a qualitative sense, whether there's more signal or less signal than you'd expect, and maybe that means there's more deposited amyloid or deposited tau in those parts of the brain. Still not indicated as being valuable in clinical practice, and I do not use these newer PET scans yet. We're still studying what value they may add to the diagnostic process, but this is not part of making a diagnosis of Alzheimer's disease or anything else right now. What I use much more frequently is an FDG PET scan. So this is in patients where an FDG PET scan is particularly useful is in patients who are presenting with changes at a younger age that have some, some components that look a little bit like Alzheimer's disease and some parts of the story that look a little bit like a frontotemporal dementia. And it's kind of 50-50, in terms of which one it is. The FDG PET scan, which shows you where the brain is using energy, is very good at distinguishing between those two. There's a very, very different pattern of decreased energy usage across the brain in AD versus FTD. And so we look for those telltale patterns to kind of break the tie and tell us which of the two it is. This is not something that is necessary for in a patient whose symptoms and history and exam look like Alzheimer's disease. This is not something that has a value in adding to that diagnosis. So, I guess what I'm getting at in kind of covering a number of these things is, if somebody is telling you that, in order to diagnose you with dementia or with Alzheimer's disease, you need to do this full battery, you need to do this EEG and do this, fancy high-tech set of scans and, run all these, thousands of labs to tell you what your metabolism is and things like that. Those are not medically indicated, and that is not part of the standard of care, not necessary to make that diagnosis and to help, treat what things are impacting your quality of life. Those things are expensive and very billable. And so there are people, unfortunately, who will do these really, really extensive and unnecessary workups as kind of a profit-making endeavor. So, that's kind of why I'm bothering to point out kind of some of these things that are not necessary for making a diagnosis. On the right of this slide, we see an example of a DAT scan. So as opposed to kind of looking at these primary dementias like Alzheimer's disease and frontotemporal dementia, this is in evaluating a patient who has some movement symptoms kind of thrown into the mix that look like they might be Parkinsonism, but might be due to something else. So if it is a Parkinsonian disorder like Parkinson's disease itself or dementia with Lewy bodies, what we'll see is that this part of the brain right here called the basal ganglia should light up in this comma shape. But if it looks more like periods, that is a decrease in uptake of this particular tracer. And it indicates a loss of a certain type of cell in the basal ganglia that is very characteristic of all those Parkinsonian syndromes. So again, I want to mention the importance of this is something that we order an awful lot of in patients who are coming to us, even if they have another diagnosis and another reason for their cognitive decline. Poor sleep can make all of that worse. In neurology, actually, poor sleep makes pretty much everything worse. If you're getting poor quality of sleep, you have more seizures, you have more headaches, you have worsening cognition. Pretty much, it can pretty much make anything worse there. And so kind of very low threshold for ordering a sleep study, particularly to identify obstructive sleep apnea. It's extremely common, it's extremely treatable, and it does cause cognitive impairment. And actually, there's a push for people to start recognizing it as a reversible cause of dementia, meaning you have dementia today, get on CPAP, and a month later, you don't have dementia anymore. And I really think I've seen enough cases that, that kind of follow that pattern that I would consider it to be a very common cause of reversible dementia. So this is something we don't want to miss. Sleep study is not the most pleasant thing, as you can kind of see from patient who's hooked up, but it is a very important thing to identify and figure out ways that we could possibly treat you. So with that, that kind of wraps up the different things that we have in our arsenal to help get the diagnosis right and to determine the best way to kind of help our patients out. To kind of start that process, these are the locations that we have at UCI Health for our memory clinic. I spend a full day each week at each of these clinics in Irvine, Laguna Hills, and Orange. And for any of those 3 locations, this is the phone number, the one ending in 7720. That is the best way to get through to schedule an appointment.